everyone highlighted is present. I counted.
All right, thank you all for waiting. We were getting set up here. We've already gone around. I'm not going to go through and call roll, but we have a quorum and I'll read the names. Me, Paul, Representative Bombach, Senator Townsend, Secretary Cade, Secretary DeMatteis, our Insurance Commissioner Navarro, Secretary Geisenberger, Senator Pettyjohn, Wayne Emsley in person, Jeff Tashner, Michael Bogato, Bill Oberly, and Denise Allen. Representative Ramon came on, and we are not going to have David with us today, so we are all present. Great. Well, good morning. We are going to jump in. Minutes were posted on Friday from the hearing for which I have heard and read in. I apologize, I wasn't able to speak. We figured out it was through the security at the White House. Figured out why I wasn't able, but Paul, thank you so much for filling in with Senator Townsend. And for those who took the time to come and share. And our next hearing will be the full 4 to 6 time frame. We recognize some of you gave some feedback. We ended a little early. There were concerns, so we'll make sure at the next hearing to have time made fully available since they ended a few minutes early that day. If there are no questions on the agenda, we're going to move right on to approval of the March 22nd meeting minutes, which again were posted on Friday. The great news for those in the room here and for those listening in, if you haven't seen, it's fantastic how DTI worked with SEBC and the DHR, and you can see the entire presentations from everyone who came to the hearing. So our minutes might be a little succinct, but you have everything there. If I could have a motion to approve the minutes, please.
Motion to approve as submitted.
I have a motion by Representative Bombach. Do I have a second?
Second. Trinidad Navarro.
Second. Thank you, Commissioner Navarro. Seconded. All in favor?
Can I
Yeah, go ahead.
discuss? I raised the question of, it noted that the Lieutenant Governor was attending virtually, but there were many members who were attending virtually. Is that, I'd suggest either not having that distinction or having it be done for everyone. I don't care which one.
Good point.
And then the second thing is in the paragraph about public comment or about the presentation. Is it useful to have it mentioned that all those presentations are available at a particular place? I'm supposed to say, hey, we had this presentation without noting that you can go and see it at this location. Is that
So put the
appropriate
link
for
in.
minutes or something, or just saying it's available at the subcommittee meeting materials, page or something like that?
We're actually incorporating all of the materials that are presented during public comment at the back of the minutes. So after the subcommittee approves the minutes, they're reposted with those presentations all embedded in the same
That's great.
document as well as separately.
Yep.
Awesome.
So then I guess I would suggest maybe taking out the attended the meeting virtually, the Lieutenant Governor's name on that.
And before we do the roll call, anyone else have comments? If not, we'll take, we've got a motion and seconded before us for approval of the March 22nd hearing minutes. All in favor or voting members, please signal by saying aye or raising your hand.
Aye.
Aye.
Thank you. The ayes have it. The approval of the March 22nd minutes have been approved. Before we jump into the presentation, I always like to respectfully turn to my co-chairs to see if they have any items they'd like to share publicly. Senator Townsend, I noticed you're there. I don't know if you have anything you'd like to add, sir, this morning.
I do not, just looking forward to the meeting. Thank you, Lieutenant Governor.
Uh-oh, the volume is low. Can you all hear me?
I can hear you. We can hear Senator Townsend as well.
All right. All right, got it. All right, thank you, Representative Bombach.
No, I'm looking forward to today's meeting.
Yeah, and hopefully we'll be able to hear you all better in a moment. I think it's on our end, but as long as you can hear us, that's important. So we are going to jump into a third item, which is asking Faith. I'm going to turn it to you, which I know you'll then turn it to.
Sure. Thank you, Lieutenant Governor. Yes, in the interest of time, what I'd like to do is just quickly refer to agenda items 3 and 4 on today's agenda and introduce the State Employee Benefits Committee's consultants and actuaries for Willis Towers Watson. They're going to walk us through these two agenda items this morning. We do have a prepared presentation that was posted on the public meeting calendar this morning and also distributed to all subcommittee members in advance of this morning's meeting. So you should have that in email as well. And again, it is posted online, and we will be displaying it virtually in this morning's virtual meeting platform. So with no further ado, I'd like to introduce Jacqueline Iglesias. Jacqueline serves as the lead consultant for the State Employee Benefits Committee. Jacqueline, I'm going to go ahead and let you introduce the other team members that are with you from Willis Towers this morning.
Thank you and good morning, everyone. So in addition to myself, also on the line this morning, we have several members of our broader WTW team, including Rebecca Warnkin, Chris Giovanello, and Brian Stitzel. And the four of us will be sort of tag teaming, walking through the material that will be presented today. We're going to be diving deeper into topics 3 and 4 on today's agenda. It'll review a brief review of the various Medicare plan options available for retired public employees of other states, including answering questions raised in prior meetings from subcommittee members as well as several members of the public. This will include an overview of how the Delaware Special Medical Plan compares to other Medicare plans, specifically around other state Medicare supplement plans, other Medicare plans available on the public marketplace, and the previously proposed Highmark Medicare Advantage plan. And we recognize that the intention is to look forward and to support that future work, wanting to set some context around some of the questions that were asked about that prior plan. Then we'll talk about Delaware's group health insurance plan projected costs for FY24, including a brief overview of how those costs are established and addressing some additional questions and deeper dive into plan costs that have been raised into prior meetings. So with that, Carol, if I could ask you to please flip to slide 4 to get us started on the state benchmarking. So slide 4 reflects Medicare plan options for retired public employees of other states. This information is based on publicly available data and includes plan options that are sponsored or established by the state as an employer or by that state's publicly funded retirement system. Now, I want to acknowledge that some states here are listed more than once, and this is to reflect instances where a state may offer a different option or series of options to different groups of retirees. So for example, Pennsylvania offers only a Medicare Advantage plans to retired state employees, but retired school employees have a choice of Medicare Supplement or Medicare Advantage plans. Now, several members of the public created a similar comparison that was shared with members of this subcommittee, and overall, their findings were directionally consistent with the results that I'm about to walk through here. So in terms of some key takeaways in this chart, there are 19 states listed, about 38%, that offer a choice between Medicare Supplement and Medicare Advantage plans for some or all Medicare eligible retirees. So this is directionally consistent with the similar analysis submitted by members of the public, which had noted that about 45% of states offered this level of choice. Additionally, 5 states provide access to a marketplace and health reimbursement accounts that excuse me, let me restate that. 5 states provide health reimbursement accounts that retirees can use to purchase a Medicare plan, either Medicare Supplement or Medicare Advantage. The other analysis also found about 10% of states take this approach. Now, 4 out of the 5 states listed here also offer access to a marketplace that helps retirees shop for and compare their options for coverage and ultimately buy a plan, which was another option that was studied by the Retirement Benefits Study Committee. States with an asterisk next to them are ones that allow retirees to remain enrolled in one or more plan options available to active employees, which would coordinate with Medicare as the primary payer. So here we're noting that about 26% of states in the chart offer this in lieu of a Medicare supplement plan, which is similar to the other analysis, which showed about 20% of states offering the plan available to active employees. One area where there was some difference between this analysis and the other one I'm referencing was in the number of states that offered access to only one type of plan. Our findings indicate a fairly even split in number between the states offering only one type of plan to some or all retiree groups. Whereas the other analysis noted a slightly greater number of states, about 29%, offering Medicare supplement plans only versus Medicare Advantage, only offering about 22% of those states. Now, one additional point of clarification before I pause and see if there are any questions or comments. I just want to point out that in prior discussions, I believe the there was a note about the states that do not sponsor retiree medical coverage today. And there was mention in a prior meeting that there were 2 states in that category, Idaho and Colorado. Upon further review, I want to clarify that Idaho offers Medicare supplement coverage to a closed group of retirees who meet certain criteria related to date of hire and the number of state service hours. So that's noted under the Medicare supplement only category here. And then finally, Colorado offers MA plans to retirees through that state's retirement pension system. So I'll just pause and see if there are any questions or comments from the subcommittee members about this information.
I do have one. Looking over the columns here, it appears to me that if I'm in column 1, supplement only, or the second column, or the last column, I have a supplement available to me. Is that correct?
And I think he's jumped ahead to chapter or page 6. Go ahead.
No,
No, you're still on page.
no, I'm right here.
Oh, you were there. Oh, okay. I thought I jumped ahead then with you. How about that?
Thank you. Sorry, go ahead.
So that would be a total of roughly 39 states, although I think there's a little duplication. It might be 37.
In that lens, yes, that choice, well, excuse me, let me rephrase that. Medicare supplement or an active employee plan would be available, to your point, in the first, second, or fourth columns of this chart.
So roughly totaling them up, that's somewhere around 37 states. There's a little bit of duplication in there.
Mm-hmm.
So 37 over 50, that's 74%, I think, if I'm correct. Is that right?
That offer that as at least one option, yes.
Thank you.
Thank you, Wayne. Denise, your hand's up. You need to unmute. Go ahead.
Here we go. Yes, I was curious if you know why some of the states, those 4 states, offer different plan options to those different groups of retirees. Do you know why?
That's a great question. And the information as to why those are offered isn't necessarily immediately available. It likely goes back to various policy decisions that were made for the various groups of retirees that do receive separate plan options.
Okay, thank you.
Thank you.
Okay, no other questions, so we'll keep moving along, Jackie.
Great, thank you. So Carol, if you could please flip to slide 6. Slide 5 that we're going to skip over is really just some footnotes associated with the prior chart. So slide 6 shows a high-level comparison of the plan options and retiree contributions for states that offer a choice between Medicare supplement or the active employee plan option and Medicare Advantage. And so what we've found here is that for the majority of states that do offer choice, in most cases, they've priced the plan options so that the Medicare Advantage contributions are lower than Medicare supplement or lower than the active plan contributions. In cases where this isn't necessarily true, those instances are largely due to those states offering Medicare Advantage plan options that only offer coverage in a limited region of the country, as opposed to offering, a plan with national access. Now, comparing the Medicare supplement or comparable comparing the Medicare supplement or the active employee plans to Delaware's group health insurance plan, MedicFill. The MedicFill plan covers nearly 100% of all eligible non-Medicare covered medical expenses. So when we look at Medicare supplement plans offered by other states, they really can only be as rich as MedicFill if they also cover nearly 100% of all eligible non-Medicare covered medical expenses. And in a few slides, we're going to get into a little bit more detail behind these other state Medicare supplement plan offerings to further illustrate just where some of those differences are coming into play relative to MedicFill. So we'll talk about that in a few minutes. Taking for just a moment the proposed Highmark Medicare Advantage plan, recognizing that there were some comments and questions about this item specifically. When we look at the plan design cost sharing provisions, so things like how much a member would pay for the cost of a PCP office visit, here they are largely aligned with the MedicFill plan as well, and we're going to get into further details on that in the next few slides also. We do want to acknowledge that Medicare Advantage plan does differ in some of the prior authorization and network requirements, but did want to point out from a pricing standpoint that plan did have a $0 premium and $0 retiree contribution for medical coverage only. So we'll get into some further details in the next few slides about this. And before we look at the other states in a little bit more detail, we're going to make just a few other comments about the MedicFill plan contributions. And for that, Carol, if you could please flip to slide 7, and I'll turn it to.
Can we stay here?
Yeah, we
Oh,
have
I'm
a-
sorry.
By one of the subcommittee members, Mr. Tashner.
Thank you, Lieutenant Governor. Jacqueline, I just want to make sure I understand the retiree premium contribution. So it would be the fourth column, Medicare supplement, MS/other. That's the amount that the retiree pays in those states. Is that correct?
That is correct.
Is that the entirety of the cost of the supplement, or is there cost in those states that's borne by the state or the employer in addition to those amounts?
These would be the costs that the retiree would pay for the supplemental coverage.
Right. So in Delaware, we provide the MedicFill, so the state pays that. I just want to make sure this is what the retiree pays. Is this the full cost of the supplemental coverage, or is there some part of it that's borne by the employer? I don't think there is, but I want to make sure of that.
In most cases, there is a cost over and above this borne by the state as the employer. In some cases, you see the ranges. There are certainly subsets where the retiree has to pay the full cost, depending upon dates of hire and service at retirement. But in general, there is an additional cost borne by the employer.
So at some point, Brian, then is it possible, because the bottom line, that's the Delaware GHIP MedicFill, is pretty much the entirety of the cost in our situation that's borne by the employer for the most part. Can we get an indication of those additional costs in these situations so we know what the split is between the plan member and the plan sponsor?
Yeah, in most cases, we know the total premium cost. We can certainly take it as a follow-up, but in most cases, we know what the total premium costs. What we likely can't get at is how many people fall at the low end of the range versus the high end of the range, because obviously we need a census in order to do that. But as I said before, in most cases, we know what the total premium cost is on average.
Right, and I think that's a significant difference from having been able to take a quick look through the deck since we only got it a little while ago. I know when you provide data later on some of these gap plans, it depends on age and other factors, what you're actually paying, whereas in our situation, it's a flat fee or a flat amount regardless of the age of the plan member who's covered, right?
Right. And on the Medicare Advantage, the last column as well, we also have for most, if not all, what the total gross premium is for these plans as compared to.
And as I indicated last time, one of the things that we've heard loud and clear from many of our retirees is the desire to remain in that gap coverage area. And I think one of the things that I in particular as a subcommittee member want to learn is, and I know we're going to get to this, Jacqueline, how does our plan compare to what's available in gap coverage? And, what's the feasibility of the state providing that coverage the way it's done? Could it be bid? And if it could be bid, what would be the possible cost of it? So thank you very much for answering these questions.
Thank you. And I gave a little leeway because Jeff, what you're getting into is the next part of our agenda later where we're going to talk about some discussion and in the future. Representative Bombach has a question, and what I'm thinking, in order to get through the presentation, you know, we might move along the presentation and hold questions till the end or relevant to the
If they're
slide.
clarifying questions.
Clarifying to the slide, maybe? Okay, go ahead.
So Jacqueline, 2 questions. The premium, that's monthly, is that correct?
That is correct.
Okay, and maybe if the slide can be updated before it's put on, maybe with that to be clarifying. Also on the supplement plans in the 3rd column, do you know the breakdown between self-funded like we have versus, you know, commercial semi off the shelf, where the insurance company is backing it and it's not self-funded for the states?
We do have that breakdown, yes. It's not always reported on state websites. From what we have observed, the majority of the Medicare supplement plans are self-funded, but where there's information available, we could certainly provide it as a follow-up.
Okay, thank you.
Great. And good. And I like the rich conversation and discussion, but I'm thinking, given our time, if we have Jacqueline go through, but again, each slide clarification. And so, you know, whether Jeff, Mike, whoever comes up with some great thoughts for the next section of our discussion, that would be fantastic. And I know at our next meeting next week, hopefully we'll be into some of those nuts and bolts too and have that data in advance. So, all right, Jacqueline, continue.
Thank you. So if we flip to slide 7 briefly, I'm going to turn over to my colleague Chris for just a couple of comments here on the Medicare plan premiums.
Yeah, thank you, Jacqueline. Good morning, everybody. So slide 7 is just the current rates for the special medical plan that were approved for calendar year 2023. No change in these rates from prior years, but really just breaking out not only the rates, but the portion paid by pensioners of different retirement dates or years of service. So certainly wanted to acknowledge that there are a number of retirees that fall into the non 100% state share. And this slide is just intended to highlight the years of service and the retirement date requirements for various retirees paying various percentages of that state share. If we jump to slide 8, then quickly, we also have a breakout we received from DHR that identifies, again, the state share percentage. So if we look at the first column here, we're breaking out separately the special medical plan as well as the special medical plan without prescription drug coverage. And then we're doing that separately for pensioners who retired both after and prior to July 1st of 2012. So again, where that 5% retiree or pensioner contribution comes in based on retiring after July 1st of 2012. So this is just meant to highlight the annual and monthly contributions for medical retirees based on those different state share percentages and ultimately the number of retirees paying those different percentages as well. So focusing on the bottom 2 sections here, there's roughly 16,000 people in the special medical plan and another 440 people who are retired prior to July 1st of 2012 that are paying $0 in contributions based on receiving that 100% state share. So when we look at contributions for the medical population moving forward, we'll be doing so in this context and making sure we're capturing the full amount of those premium contributions for this population. Any questions on 7 or 8?
And again, to members, we're getting the high level presentation, clarifying questions, and then we obviously have to get into the weeds on some of these things at some point. All right, keep going.
So picking up on slide 9, there's a lot to unpack here. So let me just quickly orient everyone to what's captured here on the slide, and then we'll share a few key takeaways here. So what we're looking at is basically a comparison side by side between the Delaware Medicare plan provisions with other states that currently offer Medicare supplement as a choice alongside of a Medicare Advantage option. We're also looking at the CMS individual market plan provisions for Medigap plans that are sold in the individual marketplace. So the specific provisions that are noted here are provisions that CMS has required be included as a standard part of any Medigap plan that is sold in the individual market. So the items here are fairly standardized and can be compared easily across those plans that do offer a true Medicare supplement plan, as opposed to the states that offer an active medical plan to retirees as well. Those states have been omitted here just for ease of reference and comparison. This isn't intended to be an exhaustive list of coverage provisions under each plan. So if we look at this, we can draw a couple of conclusions here. One, if we compare the MedicFill plan to the other plans in the individual Medigap marketplace, we can see that MedicFill most closely compares to Medigap Plan F, like Frank. We'll make note of the fact that Plan F has been previously closed by CMS to individuals who become Medicare eligible on or after January 1st of 2020. And the reason for that is there's acknowledgement from CMS that the level of benefits that Plan F provides is very rich, and to ensure the sustainability of the Medicare program, having plans that offer first dollar coverage without a deductible offer a very generous level of benefits that isn't necessarily sustainable over time. So the comparison that most closely resembles the MedicFill is the Plan F. When we look across the chart at the other state Medicare supplement plans, we can see that there are some differences in terms of the level of benefit coverage available across these various plan options. And again, I think the conclusion is that the MedicFill plan that Delaware offers is certainly a very rich plan relative to the other Medicare supplement plans offered by other states.
Okay, thank you. I know this is a lot to absorb, but it's important as we do our runway ahead. I don't see any questions. I think folks are absorbing it, and if not, we'll keep moving. Jacqueline.
Thank you. So Carol, moving to slide 10, please. We're not going to spend a lot of time here on slide 10. This is a comparison between original Medicare, the MedicFill plan in 2023, as well as the proposed Highmark MA plan. And I'll just make mention of the fact that both MedicFill and Medicare Advantage plan options were factored into the 2021 medical TPA RFP. So I think back to one of the points that was made earlier, both of these plan options were included in the 2021 medical RFP. So we're providing some additional details and drill down around these two plan options, again, comparing to original Medicare. The Highmark MA plan was designed to be very similar to existing MedicFill coverage in terms of member cost sharing. So looking at what members are paying out of pocket for various types of medical services, including the additional benefit of an out-of-pocket maximum, which is only available under the under the Medicare Advantage plan. This provides some additional level of protection for members, mainly for those traveling outside of the US and incur outpatient professional claims, like if they went to a doctor on a non-emergency basis. I do want to point out the other considerations that are also noted in this chart related to prior authorization requests and network access. In our experience working with other large plan sponsors, we have seen relatively little disruption related to implementing Medicare Advantage plans and the requirements associated with prior authorization and provider network. We understand that it is possible that disruption will occur. And certainly there's no guarantee that a given physician or provider will accept Medicare Advantage plan coverage for this or any other Medicare Advantage plan. But again, based on what we've seen in the market more broadly, working with other large plan sponsors, there's been relatively little disruption for these two items. But we do acknowledge that there are some differences in the chart. And then just to do a slightly deeper dive into both the prior authorization and network requirements, we've included some commentary on slides 11 and 12 that go through this in a bit further detail. So Carol, if you could please flip to slide 11, and I'm going to turn it back over to Brian to talk a little bit further about this first topic on prior auth.
Thanks, Jacqueline. So as Jacqueline said on the.
Are we on the same page? We want to just make sure we're following it.
We
Oh, we have a
are.
hand raised. Oh, sorry, we have a hand raised. Bill, Representative Overly, you need to unmute *6. Go ahead. Uh-oh. We don't hear you, Representative. If you want to, go ahead. Make a bad connection. Bill, if you want to text me or send a message that way, you can. And we'll try to come back to you. Sorry. You want to try one more time? Shoot. I hate it when technology doesn't work. If you want to text, Bill will connect. And Jacqueline, if you want to go ahead, we'll see if we can get Representative Overly in a minute. Okay.
Sounds good, thanks. So as Jacqueline said on the prior slide, the two main differences between the Medicare plan and the Highmark proposed Medicare Advantage plan are in the prior auth and network side. So a little bit deeper dive into prior auths. Why do carriers require them? They're looking to mitigate utilization of expensive treatments where there are lower cost alternatives, where there may be better strategies for providing cost, potentially dangerous mixes of medications, and obviously avoid treatments where they may not be needed. So there's some waste. These prior authorization requirements are not unique state by state. They're actually unique carrier to carrier. So as noted on the bottom, the major carriers in the group Medicare Advantage space are Blue Cross Blue Shield, Aetna, Humana, and United. So these prior authorization lists are unique to the carrier, not to the state. On the medical side, the prior auth ensures that the services are reasonable and necessary, and CMS sets the appeals. So any prior auth denial, the participant, the member, has the opportunity to appeal the prior auth decision, the denial decision. These standards are set by CMS, not by the plan. So CMS sets the standards for the appeals and approval process. Of particular note, CMS sets a star rating for Medicare Advantage plans. And in order to receive a star rating of at least a 4, the Medicare Advantage plan cannot have prior auth denials in excess of 8%. Highmark happens to have a star rating of 4. Their current denial rate is 7%, so they're slightly lower than that 8% denial rate. And on the prescription drug side, these prior authorizations are only specific to Part B drugs. So generally infusion type and injectable type medications. Every other prescription drug benefit would be covered outside of the group Medicare Advantage plan under the current state AgWIP employer group waiver plan. Carol, you want to flip to slide 11 or 12? I'm sorry. And on the network side, so today, how does it work today? Today under MedicFill, retirees have access generally to any provider who agrees to accept Medicare. In reality, they have access to providers who also don't agree to accept Medicare. That just means that provider can balance bill up to 115% of Medicare. But let's talk network to network. So MedicFill participants have access to, again, providers who agree to accept Medicare. Under the Medicare Advantage plan, there's a specific network of providers who have agreed to be in the specific Medicare Advantage network. So in this particular case, the Delaware Freedom Blue, excuse me, network. In both cases, traditional Medicare, MedSup, and Medicare Advantage, the providers have agreed to accept Medicare. In the particular instances where the provider is not in the group Medicare Advantage network, but has also agreed to accept Medicare like they have under traditional Medicare or under MedicFill, it's not that the participant doesn't have access to care through that provider. It's that the provider needs to agree to continue to provide care to that participant, and the reimbursement levels are the same. So take a simple example. A provider that's used today by a MedicFill participant, again, they've already agreed to accept Medicare, but they're not in the proposed Highmark Medicare Advantage plan. They've still agreed to accept Medicare. So Highmark will actually reimburse that provider at the same level that they're reimbursed under the MedicFill plan. They reimburse at Medicare limits. So while the provider has the ability to deny care because the participant's in a Medicare Advantage plan, and that provider is not in network, if they do provide care, they would be reimbursed at the same rate they would have been reimbursed under the MedicFill plan. So based on that, we believe that disruption in providers and providers denying coverage should be relatively low. As Jacqueline stated early on, experience with other clients who've implemented Medicare Advantage plans, this issue is not a major issue. But having said that, we have not done a disruption. We could ask Highmark to do a disruption between the providers utilized under the current MedicFill plan and the providers who are actually in the Delaware Freedom Blue PPO plan. I want to pause there and see if there's any clarifying questions on either of those two.
I know our secretary has his hand up, but prior, Representative Overly's comment did come to me on the prior slide, page 10, excuse me, page 10, and I shall read this. Medicare prior authorization includes only one category with 5 prior authorizations required for cosmetic surgery procedures, not a fair comparison to the proposed MA plan. So we'll put that statement in to the notes. And I know Secretary Geisenberg had raised his hand. And again, to the members listening in, those in the room, this is a high level. We have more slides to go. So go ahead, Secretary Geisenberger, and then we can certainly come back for comments and public comment at the end. Secretary Geisenberg.
So, Brian, I know that, that there's been much said about providers saying they're not going to accept Medicare Advantage. I know that as the plan was rolled out, more and more said they would. And I know you got to a pretty high, I know that Highmark ultimately got to a pretty high percentage saying they would, but can you speculate what is in it for a provider to say they won't participate? Or I'm trying to figure out if they're going to get the full amount.
Yeah.
What exactly is in it? Why would they say that they're not, even if they ultimately 30 days later ultimately do jump in?
Yeah, it's a great question. And I guess I'll answer it in part and then say that we can certainly take that back and do a little bit more research. Honestly, I believe it's nothing more than maybe a little bit of confusion on the provider side, not realizing that their reimbursement level would be the same, and that there's not really any issue to the provider to deny coverage. Other than that, I'm not really sure. But like I said, we can take back and do a little bit more research into see if we can find information relative to why a provider would not be willing to to cover a particular patient, simply by virtue of now being in a Medicare Advantage plan.
We can continue. Oh, Jeff, you have a comment there?
Yeah, and if Bill Oberly were able to call in, he would share this. What we've heard, Secretary Geisenberger, anecdotally, is it has to do with reporting and paperwork requirements and the amount of work that's placed on physicians' offices dealing with the TPA, that many of them have told folks the additional paperwork and requirements would require them to hire additional staff, which make it not, financially feasible for them. So that's what we've heard, second and third hand, through physicians that have told plan members as for the reason why they would not participate.
Thanks. I mean, I think it would be helpful to, look at other parties that have been previously said they wouldn't be part of networks that ultimately did agree to be part of networks, because there's certainly some history of that in this state. Of parties saying they wouldn't be part of a network that ultimately did become part of a network. So.
And I think there's two different issues as well, just to clarify, is one side of it is their willingness to be in the network versus not in the network. And then the other issue is if they're not in the network, issues of denying care versus still providing care as an out-of-network provider and receiving the same level of reimbursement.
Okay. Thank you all for those conversation pieces. Let's move on to slide 13.
Madam Chair, may I speak?
Yes. Oh, I'm sorry.
I didn't put my hand in.
Commissioner
I apologize.
Navarro.
Yeah, I apologize. So, commercial Medicare Advantage plans vary, right, greatly. They're not all the same. So you can buy a low cost, low coverage plan that covers, catastrophic problems, right? Versus the high cost Cadillac coverage. So the research that the retirees have done is, it's accurate. It's valid. The challenges that people have with commercial Medicare Advantage plans are significant. We've warned people about these plans for years. However, if you spend more money, you get more coverage. And I'm just kind of curious as to how the special Medicare Advantage plan that the state is offering compares to whether it's I'm assuming it's the Cadillac plan, but Brian, I don't know if you could kind of comment on that.
Perhaps we wait till a later agenda topic for that question.
Who's Rebecca?
Yeah, that was Rebecca.
Oh, Willis. Oh,
Yeah, we
Rebecca.
are intending to provide a side-by-side comparison of the Highmark Medicare Advantage plan against other Medicare Advantage commercial plans in Delaware. So we could potentially answer that now, but it might make sense to hold on that question until we get to that section of the presentation, if that's okay with you, Commissioner.
Yep.
I'd be happy to hold. Thanks.
Yep, and we'll get there, and hopefully we'll get through all the presentation. The goal was to get through presentation, have around 30-45 minutes, 30 minutes of conversation, the subcommittee to look to next Monday. At this rate, we may not get all the way there, but we can come back to that if you come back and make that decision in a few moments. So why don't we proceed with the presentation?
Yeah, thank you, Lieutenant Governor. So next agenda topic, we wanted to take a step back and talk about the methodology used in the long-term projections and ultimately how rates are set for the GHIP. So Carol, if we jump ahead to slide 14, we'll go through this slide quickly, but really we just wanted to cover again the methodology. So we started with a bunch of underlying data. We are looking at active employees, pre-65 retirees, and Medicare retirees based on reporting we get from the vendors, so Aetna, Highmark, and CVS. We are looking at both the state and the non-payroll groups as well, including the University of Delaware. We are getting enrollment information from the experience period from the vendors. We're getting claims information, not just claims, but things like rebates, things like the employer group waiver plan, subsidy payments. So again, those are subsidies tied to the prescription drug coverage offered to Medicare retirees. And we also utilize the monthly health funds to understand expenses and claims in real time as they're being paid by the state of Delaware. And we're always looking at 24 months of historical claims experience, and we weight the most recent 12-month period 65%. That can vary. So when we think about COVID and the impact that that had on the experience period, we'll make adjustments as needed. But typically, we're always looking at 24 months of experience with a 65% weight on the most recent 12 months. So that's the underlying data. And then all of that goes into our underwriting models. We are taking claims experience and combining it for all groups. So actives, pre-65 retirees, and Medicare. We adjust the claims experience if there are any changes or initiatives adopted by the SEBC. So think of plan design changes. So when we change copays for high-tech imaging, that's something that will be used to adjust the future experience. Legislative changes, anything that will have a cost impact on the GHIP would also be factored in as well. We're looking at claims on an incurred basis. So we adjust the claims from a paid basis to an incurred basis using what are called IBNR factors, or incurred but not reported factors. We adjust claims to future projection periods using trend. Our trend assumptions are approved by the SEBC periodically, typically annually, though they haven't changed in the past couple of years. We offset the claims for any additional revenues that the state receives. So things like prescription drug rebates and those EGWP subsidies that I touched on already. And then we also factor in administrative expenses and fees as well. So that is all that is going into the pie that ultimately projects out the operating expenses, as well as those other revenues that can be considered offsets to those operating expenses. And once we have that expense figure, we're then calculating a uniform rate action that gets applied to all plans, including MedicFill. So it's important to know that it's one rate action based on the GHIP experience as a whole, and that the individual plan options based on this methodology, they don't align with the actuarial value of the specific plan. So points we just wanted to make sure the committee is aware of. The best practice recommendation for rating would be to rate actives and retirees separately based on their own experience. We've had a number of conversations with the subcommittees and the SEBC about this practice. I think most recently in October, we had an exhibit that showed if actives and pre-65 retirees were rated on their own experience, it would be roughly a 10% rate increase for actives and a 40% rate increase for pre-65 retirees. So it's a conversation that's been had, but there have been no changes to this rating methodology for a number of years. So it's just important to understand we are looking at the GHIP in total and not looking at experience for the different buckets of participants separately. So having said all that, if we jump to slide 15, slide 15 is just our long-term projection exhibit from the most recent SEBC meeting. Again, we were targeting a 3-year smoothed rate action to target a $0 deficit in FY26. So this version of the chart does reflect the 9.4% rate action that was voted on by the SEBC earlier this month. That rate action again applies to actives, to pre-65 retirees. Historically, it would apply to MedicFill retirees as well, but more needs to be discussed in terms of any potential changes to that population, as we all know. So for the time being, active and pre-65 rates will all go up uniformly by the 9.4%, and that percent will apply for every plan, for every coverage tier as well. Again, just based on the methodology we previously touched on. When we do look at the long-term projection, so the premium contribution row, that is aggregate premium. So that includes the state share, and it includes the full amount paid into via premium contributions by those actives, pre-65 retirees and Medicare retirees as well. jumping ahead to slide 16, then it has been brought up, can we look at the long-term projections for the different populations? So we've broken that out on slide 16, where we're taking just the FY24 projection and looking at it separately for actives, pre-65 retirees and Medicare retirees. I think the conclusion here, the bottom row of the table, the adjusted net income, that would be any surplus or deficit generated for each of these populations. So no surprises here based on the quarterly reporting that we typically share with the SEBC, and also consistent with some other presentations that have been presented to this subcommittee as well. But actives and pre-65 retirees, based on how those premium rates are set today, they do generate a deficit, while the Medicare retirees generate a surplus, so $25.1 million there. But again, these deficits and surpluses are a function of the premium setting, which again is done uniformly. So taking a further step back, the GHIP is a self-funded healthcare program. So what that means is premium equivalent rates are established to generate the necessary revenues in order for the state to be able to pay for the healthcare obligations. In a fully insured plan, the premium contribution is really the expense to the state or to the participant. But in a self-funded plan, the state is obligated to pay the claims. The premium equivalent rates are just a funding mechanism to generate the revenues to help pay for those claims. And as we've already kind of touched on, those revenues or those premium rates are determined and funded in aggregate to offset the total GHIP projected expenses. Those rates apply uniformly to all plans and all populations, again, including the Medicaid population. And those individual plan rates do not align with the underlying actuarial value of the plan option. So having said all of that, we cannot look at premium rates by population. We need to look at them in aggregate. So anytime we are trying to assess whether one group is performing favorably relative to their premiums or unfavorably, we just want to emphasize that we need to look at that in totality and not break it out by the separate populations, because again, those premium rates do not indicate any expectation for cost for these populations or plans. They're truly a funding mechanism for the GHIP in totality to be covering their expenses with those revenues being generated. I'll pause there and just see if there's any quick questions before we jump to slide 17.
No hands raised.
All right, so then on slide 17,
Yeah,
oh, sorry.
Sorry.
a real
Wayne.
simple question. Where do you come up with the 29,290 members? And on page 5, I'm sorry, page 8, it's 24,556.
So that is a great question. So the 29,290 is state and non-state retirees. The 24,000 on the prior slide you're referencing, I believe, is just the state retirees. So when we, again, in the, when we're doing the long-term projections, we're including everybody, all expenses, all revenue. So I think that's the difference.
What do you mean by non-state retirees?
We're talking about groups like the University of Delaware and other groups that are permitted by statute to participate in the health plan.
Municipalities and other partners.
Why aren't they included on page 8?
Because that is reporting strictly from the Office of Pensions that's breaking down the state share contributions for our state retirees. We don't get involved in what the cost sharing is for the groups that participate in the health plan that are outside of being covered under the state pension plans. They make that decision.
Okay, thank you. Good question, Wayne. Thank you. Okay, you can proceed. Go ahead.
All right, so then jumping ahead to slide 17. So we also want to acknowledge that there are different ways that each population pays for their own healthcare expenditures and how that relates to what the state ultimately is responsible for in net operating expenses. So the first column here, net operating expenses, that's really the expected cost to the state for these claims and fees. So it's taking your gross operating expenses in the long-term projections chart and then applying those offsets like rebates and those EGWIP subsidy payments to understand, okay, what does the state owe for healthcare in any particular projection period? Part of that cost then is funded by employees and pensioners through premium contributions. So the middle column here represents the amount paid in premium contributions for the different populations, with the difference then being the amount the state picks up. So the percentages on this slide represent, okay, what percentage of that total cost is picked up in premium contributions by employees and pensioners. You can see in total, it's about 9%. Meaning employees and pensioners cover about 9% of the projected cost, while the state picks up the remaining 91%. And then you can see how it varies by population. So actives paying about 10% of their projected cost, the Medicare retirees paying about 5%. So again, this includes the scale of state share closely or more closely aligning with the chart we presented earlier that Wayne just referenced. So no longer making assumptions based on some limited reporting available to us, but trying to highlight, okay, what is the more accurate representation of Medicare pensioners' contributions, and that's about 5% then of the projected cost in FY24 for that population. So that's premium contributions. There are also out-of-pocket expenses that employees and pensioners pay at the point of care. So that's things like your deductibles, your co-pays, and your co-insurances. So that becomes an additional expense as well. We have talked about the fact that the Medicare plan covers nearly 100% of the expenses not covered by traditional Medicare. So that what that means is there's very limited out-of-pocket expenses then at the point of care based on that plan design. We do acknowledge, though, that Medicare retirees pay a Part B premium. So that's about $164.90 per month in 2023. That's a significant out-of-pocket expenditure, but those premiums do not fund or offset any of the state's expenses. So that's really a separate bucket of money that does not help the state cover those net operating expenses. So just want to keep that in mind as well. But when we think about out-of-pocket expenses then by population, based on some meritive reporting we've received, the most recent 12 months in out-of-pocket expenditures for active employees is about $26 million. It's about $3 million for pre-65 retirees, and that's very minimal again for MedicFill population based on that plan design. So really the goal here is to provide some information based on some asks we've received from the subcommittee members previously, but also just to make sure we're understanding the bigger picture when we think about premiums, when we think about expenses and how they apply to the different populations. We certainly just want to make sure the methodology for determining those premiums is understood, especially if using different reports to try and compare different populations, which as mentioned, we've recommended and stated with the quarterly financial reports in the past that we really need to be looking at things in aggregate based on how those premium rates are set.
Thank you, and we'll keep you going. We had slated you for an hour, which is around 12 more minutes. No pressure, but we'll do the best we can, and we'll reevaluate where we are around 11:15. Go ahead.
So I think we can now flip to slide 19, and I will try to cover this as quickly as possible, but please stop me if we do.
These are important, but these are important, yeah. Okay.
Absolutely. So what we plan to do for the next several slides is provide a little more detail and overview of the plans that are available in the individual marketplace in Delaware, and how the costs to retirees compare to the MedicFill plan, as well as the Highmark Medicare Advantage plan. And to start on page 19, to level set of the types of plans that are generally available in the individual marketplace. And we did touch on some of these already earlier in the presentation, but just to kind of summarize in one place, there are Medicare supplement plans, or also known as Medigap plans, that all are labeled with a letter. And we're showing 3 sample plans here, but there's a number of different options ranging in plans that have lower premium but higher costs at point of care. So on one end, Plan K, and then plans that have higher premiums, but then lower costs at point of care. Jacqueline mentioned Plan F as the most generous plan, but that plan is closed currently. So what we plan to do is focus on Plan G as representing the sort of most generous Medigap plan option available on the marketplace today. Medigap plans are medical coverage only. So typically a retiree purchasing Medigap through the individual marketplace is also purchasing a standalone Medicare Part D prescription drug plan. The other type of plan available are Medicare Advantage plans, and typically those are going to be Medicare Advantage plus prescription drug plans, or MAPD. There's two types of Medicare MAPD plans. An HMO plan is one where you do need to use a network provider and may require a referral. The costs and plan designs vary, and we do have some examples in a couple of pages of exactly what's available in Delaware. And then there's the PPO type plans, and that's the type of plan we were discussing in the earlier section. So you're able to use network and non-network providers, with the caveat that a non-network provider, provided again that the provider does accept Medicare, and the non-network providers can refuse service. Wanted to also clarify, when we say network, Medicare Advantage plans typically have a national network. So even if you're purchasing a plan in Delaware, so for example, the Highmark Delaware Medicare Advantage plan, the carriers all have a national network. So you can find generally providers outside of your home state or your location where you're purchasing that plan. The Highmark network, for example, is the Blue Cross Blue Shield Medicare Advantage PPO network. Specifically in Delaware, there are 8 Medigap plans, so 8 lettered plans across 2 different carriers. There are 18 Part D prescription drug plans, and those are represented by 6 carriers. And then there's 20 Medicare Advantage plans across 7 carriers. 16 of those Medicare Advantage plans are MAPD, so include the prescription drug coverage. And then we also took a look at the plans and carriers that are available across the entire footprint of state of Delaware Medicare retirees. So when we're looking at individuals that also reside in some states outside of Delaware, the numbers go up a little bit. So we have 23 Medigap plans across 3 carriers, 20 Part D plans across 7 carriers, 35 Medicare Advantage plans across 8 carriers, and about 98% of retirees have access to one of the Medigap plans. And 96% of retirees have access to a $0 Medicare Advantage plan. However, to the commissioner's comment earlier, and we'll see some details later, many of those plans do include some higher cost sharing at point of care. So I think we can jump to the next page unless there's any questions. So this is a comparison of the Medigap options available to what a retiree has today under MedicFill and would have with the Highmark Medicare Advantage plan from the retiree's perspective. So this is somewhat of a repeat slide that Jacqueline presented earlier, but looking sort of at the dollar amounts for the retiree across the different options. On the right-hand side, as mentioned, the Medigap G plan is the plan that is most similar after Plan F to the MedicFill plan, with no deductible for Part A, no cost sharing for Part A services, but the retiree does need to meet the Part B deductible, of which is in 2023, $226. And then after that, the plan covers everything for the remaining Part B services. Medigap N is also a popular option. No cost sharing for Part A, but you do need to meet that Part B deductible, and there's co-pays for most services under Part B. And then Medigap K is the leanest option that we're showing here, where the member has to meet 50% of the Part A deductible, which for 2023 is $800. And skilled nursing is covered at 50% coinsurance. Members also have to meet that Part B deductible, and then services under Part B are covered at 50% coinsurance, and there's a $6,940 out-of-pocket maximum. So quite a bit leaner than the other 2 Medigap options shown. And we've also noted here that there's no cost sharing for the current GHEP MedicFill plan, and no plan cost sharing for the Highmark MA plans. The Medigap plans are standardized across all carriers and geographies. So what we're showing here would be true in Delaware or any other state from any carrier. Employer-sponsored group plans do have more flexibility in designing plans and programs that aren't required to follow any specific plan design. All right. If there's no questions, so I'll provide a little context and overview of the slide. I know there's a lot of numbers here, but when we want to compare what is the cost of a Medigap plans or Medicare supplement plan in the individual marketplace, there's a couple of things to keep in mind. So first, reminder that the Medifill plan is a self-funded plan. So the cost to the state is going to be the claims and the administrative fees for the plan. The marketplace plans are insured, so the cost to the state or participants will be the insured premium rates, which includes taxes, risk margin, and profit loads that are not necessarily applicable to self-funded plans. So we acknowledge there's not quite an apples to apples comparison here because one type of plan is insured and one type is self-funded. We're also comparing the Medifill age-adjusted claim costs here, which are pulled from the post-retirement health plan actuarial evaluation report as of July 1st, 2022. So even though there's one rate for the Medifill plan, we are able to see what those age-adjusted claim assumptions are based on that actuarial report. And we acknowledge that expected costs do increase with age. For the individual marketplace plans, carriers are able to vary premiums by age, and the rates also typically vary by zip code and what plan you've selected. So what we're showing here in the pink, blue, and orange lines represent the average lowest monthly Medigap premium by age for 2023 across the state of Delaware's retiree footprint. So sort of a weighted average of what plans based on where someone lives, based on those zip codes, what is that average, weighted average, lowest premium plan, premium option for each of the plans listed. So again, not apples to apples. The Medifill is medical only claims, and then we have the plans G, N, and K, but gives you a sense of how the cost of Medifill compares to the premiums for those individual plans on the marketplace. Wanted to note Plan G, as we saw on the prior page, does not cover that Part B deductible. So can potentially think about that too as a cost for retirees that Medifill does cover. All right, I'll keep us moving here in the interest of time, unless there's any questions. Let's jump to 23. And now we're moving to a comparison of Medicare Advantage type plans. So at the very top, we have the state of Delaware's Highmark MA plan. We're showing just for medical only. As a reminder, coverage for prescription drug is separate through the CVS employer group waiver plan. So what we're showing here is the premium of $0 for the medical portion of that plan, as well as the $0 cost sharing with the $1,000 out-of-pocket maximum. The other plans listed here are other Medicare Advantage prescription drug plans or MAPD plans available in Delaware. So we're showing monthly premiums that are inclusive of both medical and prescription drug, as well as what are those deductible and copay and out-of-pocket maximum features. And as we would suspect, generally the plans that have the $0 premiums have other plan features that require expenses to the retiree at point of care.
Okay, thank you. I know it's a lot for folks, but we have it in paper and we have it online. All right.
Okay, and then just to bring us home here, so in thinking about the comparison, it's important to consider both what a retiree is paying in premium costs as well as out of pocket. So we did model one illustrative scenario, again, recognizing there's thousands and thousands of scenarios that we could model, but picking one retiree that's at a 50th percentile of claims. So if we think about the claims curve and all the different different utilization that retirees have, if we pick somebody who's at that 50th percentile and also at the 50th percentile in terms of the cost of coverage where they reside, that's essentially what we're modeling here. So middle of the road, an individual who would be purchasing coverage on the individual marketplace. K, G, N are modeled, as well as 2 Medicare Advantage prescription drug plans. The top row represents what the retiree's premium contribution would be. For Medicfill, that ranges $0 to $276 for the year, assuming that that retiree is eligible for 100% state share. We know from prior pages it's more complicated than that, but again, for the sake of modeling, that's what we've modeled. And then those retiree premium contributions across those individual marketplace plans. We then have modeled the out-of-pocket costs for medical and prescription drugs separately. So Medicfill, the total out-of-pocket for that 50% person is $393. And then we also show across the other options what the average 50 percentile out-of-pocket cost would be. And then at the very bottom. So for Medicfill, the total retiree cost, including both that premium contribution and the out-of-pocket, ranges $393 to $669. And that's compared to, without any other financial assistance, what a retiree would pay for the plans on the marketplace. So a lot here, I recognize, a lot to digest, but to give us an order of magnitude and sense of what these costs, what these plans cost in the marketplace in terms of both the contribution and the out-of-pocket.
Rebecca, Representative Bombach has a question.
Rebecca, could you come back and fill in the bottom row, those other 5 entries with the estimate of what the state contribution in the other 5 columns would be?
And if you can't do it right now.
I'm not
we'll have
asking
to-
for it right now.
Well, I think that's up to the state to decide. You can subsidize individual marketplace plans at any level.
But you are figuring out, you know what the premium contribution at 50th, you're making assumption that we're doing a 50% share, correct? On under the retiree premium contribution, that leaves the state the other 50%. You know that, right?
So what we're intending to model here is for a retiree that goes and purchases their own coverage on the marketplace, what would their cost be? We
I
could
was
potentially model
assuming
if
as the state
also-
was.
He was looking at the
I
state
assumed you
side.
meant the state was contracting on behalf of the retiree, a K, a G, or an N on their behalf, and the same with Medicare Advantage. Is that not really the underlying assumption?
The contributions shown for the Medigap plans as well as the MEPD plans are based on the premium rate that's available in the marketplace today, if someone were to go out and purchase their own coverage.
So the right 5 columns is a pure, if you go off on your own, if you're not a retiree, not getting anything from the state. So,
Correct.
so it's a on the side, but it's not, it's a little bit of 2 different brands of apple between the left column and the other
Correct.
5.
And
Okay,
to
thank you.
clarify on the 50th percentile comment, because the premium rates vary by age and zip code and other factors, the 50th percentile represents, if we kind of lumped everyone in the Delaware together and sort of stack them across where based on where they live and their age, the 50th percentile is that average premium right in the middle.
Thank you. That's the annual, I'm sorry, that's the annual premium contribution, right? Thank you.
Okay. All right. Well, that is a lot, but we thank you. I do want to recognize the team here, the DHR team and Kristen and Willis Tower Watson. That was a lot to put together in a week for us. So number one, I know the co-chairs and I really thank you for doing that. We are going to go and merge, if it's okay with members. It makes sense, and we have some questions, and I have some things from Representative Overly as well. We can merge kind of the conversation about Medicare plan options. I believe, unless, you know, anyone here or any of the others listening in or cabinet secretaries feel differently, we're looking at merging Medicare plan options and open discussion for a subcommittee, given our timeline. So we have, you know, some homework for next Monday. We have to give to the team here at DHR, what we kind of want them to look at as possible options, modeling, what we want to talk about when we come together. We've all talked about the roadway. This is kind of the meat of our work, you know, what do we want them to look at? And so I don't know if we want to turn, if I want to turn to co-chairs or members, subcommittee members. So what do we want to look at? Like we know that we have the predetermined, we know what it is to do nothing, what it's going to cost for the state. And we know on the other end, Medicare Advantage, and we know somewhere in the middle of that curve, that in the middle of that is where our goal is. And so I don't know, Representative, if you want to start or somebody else does.
So if I could, if you go to slide 16, and this material was presented similarly at the last meeting. When I look at the quote bottom line there, what I see is that for the projection for fiscal 24 is deficit for actives, deficit for pre-65 retirees, and then a surplus for our Medicare age retirees. My question for you is, can you help us understand of the roughly $8 to $9 billion shortfall actuarially over the next 30 plus years, what proportion of that is coming from these three subpopulations? If, for instance, in fiscal 24, I'm going to say the way that we have everything structured, the Medicare retirees are covering their costs. Is that expected to reverse and have them in a deficit over the next 30 years, and to what extent? What proportion of these, I view it as a hole in the ground, is coming from the three different populations? And that's what I would love to see. And I know that's not something you can do off the top of your head, but I would love to see that information.
Okay.
Thank you.
So, and if other committee members would like to share, I think we all have heard, different options. So why don't we do this before we talk about plan option per se? Are there comments or questions on the data presentations that were given here to date? And so that kind of fits into what Representative Bombach said. I know Senator Townsend, I don't know if you have anything you want to weigh in before we open it up to others.
Thank you, Lieutenant Governor. I just want to make sure everyone can hear me.
Yes, we can.
Just very briefly, I guess I'd say obviously a lot of data, a lot of comparison, a lot still to be determined. And I think to the extent that there are retirees who are looking to have an option to stay with some kind of medical supplement program only and not have Medicare Advantage, that's certainly one topic that we're looking at. But even for those who ultimately would choose to go Medicare Advantage, even in a world of choice, I'm curious, not only with the presentation today, but just it seems like this is a topic that we continue to learn more and more about as there's more and more data or analyses, or criticisms that happen around the country with different Medicare Advantage frameworks. And I think that Commissioner Navarro had already pointed out that not all plans are equal. And I think it's a great point that he made. So I'm not trying to say at all that all plans are equal, but I am curious, I guess, kind of how this sort of analysis could be modified, sort of moving forward, literally 6 months from now, 12 months from now, on a timetable where final decisions might be made with regard to what long-term options look like in Delaware. What can we learn from other? What can we learn from other jurisdictions? What changes is the federal government proposing? Like how would all of this change in a dynamic world as more and more people are learning about, things that maybe can and should be improved about a Medicare Advantage framework? So I just wanted to note that as complicated as this presentation is, and as Lieutenant Governor mentioned, the meat of what we're doing here really relates to so much of what can be gleaned from these slides. There's more to glean, I think, also as we learn more and more around the country about this and what changes are coming down the pike from the federal level in particular. So I just wanted to note that, and and as we move forward, that's kind of where my head's at.
I agree. No, thank you. And I think that fits nicely into, like I said, the spectrum of what it is to do nothing for our state, which we know really isn't an option, to the extreme of the Medicare Advantage, but looking at the data points, what other states are doing, whether you're looking at Medicare Advantage with medical bill supplement, I think as we begin that roadmap, and even, whether the issue with, which didn't come up here today, but something I know was talked about in previous studies, HRAs, et cetera. Specific to the slides that were here today, I did have a comment from Representative Overly. This was not from me, this is from Representative Overly, and I know Jeff's hand's up, so we'll go to you next, Jeff. Representative Overly requested, such as Representative Bombach did for our next meeting, if the question could be answered, if an analysis can be done based on the historical attrition rate, and I'm smiling, I did not say this to everyone in the room, meaning your mortality, your death rate. So you're getting a chuckle, Bill. I would like an analysis done based on the historical attrition rate of retirees, but it's a legit question on retirees. and the impact to the OPEB liability if we were to grandfather retirees into the Medicaid program. Again, what would the analyses be based on the historical attrition rate of retirees and the impact to OPEB liability if we were to grandfather retirees into the Medicaid program? And he's kind of guesstimated around an 8% attrition rate from his own guesstimations. And so that is a question then that has been submitted. Mr. Tashner, your hand's up.
Thank you, Lieutenant Governor. And I have, I think, 4 different questions for the Willis Towers Watson Group for information that I think will be helpful, at least for me going forward. First is on slide 4. The 5 states that are listed as providing an HRA, do we know the amount of the contribution that is given to the retiree? And do we know if there is any anything built in to increase that cost over time? So we've talked about the Retirement Benefits Study Committee. This was an issue that myself and Mr. Bragato raised there when this was brought up, where there's going to be a crossover point at some time in the future with the amount the state's contributing now and whether it would be sufficient to cover the costs for retirees. So I'd like to know, what do these states give retirees? And do they have anything built in to cover the projected increase so that we don't get to a point where what we're providing is insufficient? Should we go that route? Page 9, there's a footnote, and I know that both Jacqueline and Rebecca alluded to this in regards to the availability of F. And it says here that something about if individuals might be eligible if they were enrolled in Medicare prior to January 1st, 2020. I'd like to know what that means. If we have people who are in our retiree population now and they were enrolled in Medicare before January 1st, 2020, is F a possibility for them or not? Would we have to treat them differently than others? At one point I read this footnote, but I thought I heard it was also that it was closed. Is it entirely closed? Or is there some way in which people that were enrolled prior to January 1st, 2020 are in fact eligible? Flipping ahead to page 20. I just want to make sure I understand this correctly. And I think what I heard Rebecca say is the only difference between the GHIP Medicfill and Medigap G is the Part B deductible of $226 a year. And I'm just going to be really blunt. I would like to nail that down and have a definitive statement, because quite frankly, I'm concerned today when I hear that the Medicare Advantage plan, I think the words used today, were designed to be very similar to Medicfill. But when I looked at the documents that were provided in January 2022, it says same as Medicfill. And I know I don't always get everything right, but to me, very similar to and same as is a very significant difference. So my direct question here is the difference, is the only difference as explained today between the GHIP Medicfill and the Medigap G, the $226 Part B services deductible on an annual basis? And then lastly, on page 23, Rebecca just went over this, and Representative Bombach asked about the medical at the 50% level. What I'd like to know is what are the outside? What's the variation? Are we talking that's the 50% level and there's a variation of $100 on the high side and low side? Is it $300 high side and low side? Because that impacts the overall cost and the ability of the state to possibly cover everybody through one of those Medigap coverages. So those are the 4 specific areas that I have questions. Hopefully they got them down. If not, I'm happy to follow up with anybody after the meeting. Thank you.
Thank you. I think we had those, and we have Secretary DeMatteis and then Wayne's hand up. Secretary? Oh, you need to unmute, ma'am. There you go.
Oh, thank you. Thank you, Lieutenant Governor. First, Chris, you've mentioned in passing the importance of taking our premiums in aggregate, meaning that the reason Highmark gives us such favorable pricing across active employees, pre-65 retirees, and Medicare pensioners is because they're basing their rates on that 100,000 people mark. That if we were to just go with a separate carrier for Medicare pensioners versus active and pre-65 retirees, we would get a much different rate that we would need to charge a small group of Medicare pensioners. Can you talk about that a little bit more? Because I don't want that point to get lost.
Yeah, Secretary, happy to try and address that. I know when we talk about the rates again, the rates are what the state is ultimately paying. So those premium rates are not set by Highmark and they don't factor into the expected costs. I know with the group Medicare Advantage quote that was originally evaluated, the premium rate tied to the group Medicare Advantage plan was based on an enrollment threshold. So the $0 premium would only apply if there were a certain number of active pre-65 retirees enrolled in the Highmark plan. So there, to that point, there was a correlation between enrollment in Highmark plans and the premium rate that they were willing to offer to the Highmark retirees that would potentially be in that Medicare Advantage plan. Does that answer your question, Secretary?
Yeah, I mean, the overall point is how we finance our healthcare and keep it affordable is because it's across a broad spectrum of an aggregate group of active employees, pre-65 retirees, and Medicare pensioners.
That's right.
Okay. Well, thank you both for those. And Wayne, we'll go ahead to you, sir.
Yes, thank you. I have two data requests. Well, one's a data request, the other is an explanation. Neither need to be given now. On page 11, could you indicate, you indicate that there's purposes for prior authorization and you list mitigation and avoid. Could you get some percentages on how often those things occur, or some rate or whatever of how often they occur? And for the 7% denial rate of Highmark, I need to know whether that's denial forever or just denial at one level and approved at a higher level.
We got that question. Representative Ramon.
Thank you, Madam Chair. I wanted to just ask two questions at the very end, but just to address a couple of things that have been brought up. It seems like a lot of effort during this is being put into justifying the modification and the purposes of doing anything. I mean, I think the ultimate function of what we're trying to do is address not just the $8 billion shortfall, but the fact that the trajectory is going to get worse than better. But like Representative Bomback had said, when we're addressing the $8 billion shortfall and we're trying to create an environment where we're not being irresponsible in that, placing numbers and giving a portion of the presentation that shows how all these things affect each and every portion, I think is extremely important. But for instance, I guess Secretary DeMatteis was saying about putting the three groups and how it all blends and you need the big package. Well, okay, so what would the difference in the math be if we just sucked out the retirees group and had the rest in there and could modify compensation to offset savings for their health care? What would it be if we took into consideration, like Representative Oberly is saying, I know I was told the last meeting that it was taken into consideration, but I've done the research and it wasn't. The last 2 years, the average age expectation has actually dropped for the first time in the history of our state. And has that trajectory been included in the estimators? And it hasn't. I asked the question and I was told it was, but I looked up the numbers and the year they're using doesn't include the 21-22 drops in average ages. And therefore, how does that average age expected to drop or change the estimators numbers? I mean, I hear what we're doing and I see all the options and how we're making all these comparisons, and it's really not as bad as everyone thinks concept, but I don't really have as much importance of that as I just want to see the math. You know, we clearly have heard from the people in our districts and in our state that the retirees are extremely concerned with being deprived the ability to use who they want, when they want, how they want. We also have a clear issue that we're trying to address with maybe some overuse or unreasonable use and expense, and we're trying to have that addressed also. But how do we do that and still be able to please our constituents who are the retirees on the state pension and enable them to keep what they have? And if we did just that carve out, how does that affect everything else? The last two pieces of that I didn't hear as well as I want, or maybe I wasn't understanding, was how it's affecting, this thing about the doctors not all joining. Well, why aren't they joining? I mean, can we ask them? Can we go to 10 or 20 or 50 that aren't joining and say, what do we need to do better to help you all join so that everyone has more choices? And the second is, how does that choice then affect those who are retired and not even living in Delaware? So there's just some of my questions and issues. I'm not looking for answers. I'm just saying, I think that those points for me are extremely important of what I'm trying to hear so I can help make everyone happy and find a path that does that. So thank you.
No, thank you, Representative. Before we continue, I know Representative Bombach is going to be here. I am going to be listening in remote. Something has come up that I have to attend a meeting unexpected. I have to be in Wilmington in 45 minutes. Wanted to mention, though I will be listening, we absolutely need to answer your questions. All health providers, whether it's the Medical Society, the advanced practice nurses, are aware. We certainly will have a public hearing again in the late day, early eve, where individuals can come. Representative Bombach and Senator Townsend have the remaining agenda. Our goal is to have an agenda out for next week's meeting, where I hope that we do a lot more of the hardcore question answer, laying out options kind of on a visual scale, from doing nothing to the Medicare Advantage to the middle of the chart, right? Medicare supplement, HRAs, et cetera, which Paul can talk about at the end. Right now, let's continue questions that we need answered for that meeting. And also, recognizing too, for those who were not at the hearing last week, that our Secretary DeMatteis did mention the SEBC is taking their vote, on the 4th around the extension around the state contract. Failed to mention that earlier. So
April 24th.
April 24th. I'm moving it up, Claire. How about that? I'm trying to move it up. All right, Representative Bombach will take over, but I will be listening in.
Okay, thank you. So these are things that I'd like to see more information from WTW presumably. So on slide 21, it looks at Medicaid versus the commercially available ones, and I'm using Plan G as the baseline of the supplement for projection purposes. Again, as it relates to the long-term projected deficit, what is the impact? I'd like to see the impact of sticking on self-funded versus switching to commercially available, where that risk pool is on the insurance company and not the state. It certainly looks beneficial, and actually on the slide, it's certainly the difference is less than. The difference is more than the $268 a year. The Part B excess deductible. So I'd like to see that as I think Mr. Tashner pointed out on slide 23, 50th percentile is good, but that means that 49% of people are covered or have a worse experience than that. So I don't know what is standard in presentations, and passing on to WTW. I would think that a 10th and a 90th, and or a 20th and an 80th would be helpful in understanding the impact beyond what the middle person in the state would experience. And then I really liked, I think it was also Mr. Tashner's point of finding out for the states that use the HRA, how many include some kind of cost of living as opposed to a static dollar amount that stays there forever, which is really great if you retire this year, but if you retired 30 years ago on a flat amount of an HRA, much less really good. So I think that would be helpful in being able to judge across different choices. The issue of all these, I'm going to say, side ways to make improvements, you know, the spouse, you know, covering the spouse of a deceased employee, you know, all those elements. I know we had that in a slide last week. I'm assuming that is something that we'll be looking at next week when I'm looking to Faith to see if I get a head nod on that. But seeing, we're looking, I think, for a menu of, you know, if we go this direction, go HRA, if we go for Medicare Advantage, if we go for choices, I think we also want to be looking at the different side options that were explored by the RBSC in the past. So I think that's useful. And then the grandfathering, trying to figure out what grandfathering means. Is it for all new hires and those with less than 10 years experience? Are there other basic models of grandfathering that we should be looking at so that we know that when we say grandfathering, we're using the same language as all of us, and it's not one person's grandfathering, it's a very different version of another person's grandfathering. I think that would be helpful. I'm looking to see if there's any more hands for subcommittee members. Obviously, remember next week's meeting. I mean, even at the time next week, Monday 12 to 2 or something like that.
12 to 2.
Okay, that's great. With that,
Mr. Chairman,
please.
I do have I'm not sure if it should be a motion or a request. We received, this is great material, and I really appreciate all the effort that went into it. But 2 hours before the meeting is way too short a period of time to receive it. It seems to me 48 hours is reasonable for the future meetings. Again, I don't know if that needs to be a motion or just by consensus, but
if I'm going to ask you, is it okay if we commit to best efforts to get it to subcommittee members 48 hours or more ahead of time? And
let's say best efforts are 24.
Yeah, and I know because I've had correspondence with DHR over the weekend. They work 7 days a week, and it's insanely wonderful.
Right, and I don't mean to denigrate anything that they've done. They've done a great job, but again, our job here is to represent various entities, and I can't do it on 2 hours notice.
And the other thing I'll say is we have to take some of the blame because they sent stuff to us saying, can you look this over? And we have to on a Saturday or Sunday go through and say, oh, can you tweak this or this before it goes out so it is received best and is most constructive. So I think we will all increase our efforts to try to get it to all subcommittee members. Our goal is 24 hours. I'm not ahead of time. I'm not seeing people's heads explode.
Well, that's because I'm doing my best for it not to. But I represent with all due respect, this is a quite lofty list of requests for a meeting that is 1 week from today. I think as I've heard and quickly tried to document the takeaways, I want to be very clear that some of this falls under work that would need to be done by the Office of Pensions Actuary, okay, not Willis Towers Watson. We need to regroup with the pension office and their actuaries and the Towers team to go through this long list and then start to figure out what we could realistically provide in a week. I can assure you we will not be able to accommodate all of these requests for next week.
I don't think anyone in the subcommittee expects that. Okay, I think that when Mr. Tashner, myself, Mr. Emsley, and others have said we'd like to see this We're not saying we're expecting to see it 7 days and then back off of there to nowhere. We want you guys to go. The pace you're doing is terrific and so appreciated. Is that what you share
Yeah,
that?
but again, whatever we're gonna cover at the April third
Exactly.
meeting,
Yep.
audit needs to be available. And again, if you can't get all the data that we requested, I understand that.
Yep.
You know, I'm trying to be human here, but again, we have a responsibility to do this well, and we can't do it well with 2 hours notice.
Can we go without a motion? Are you all right with
I'm
that?
fine with that, as long as there's an understanding.
Okay, I think we
Sorry,
got that.
Representative Wambach, if I could briefly.
Please.
Yeah, no, I think my main takeaway from that, I think it's a great comment, would be it's incumbent on yourself, myself, Lieutenant Governor Hall Long, as the chair and co-chairs, to then work with Faith and her team to figure out which items, you know, we might have wanted to see next week, but really shouldn't plan on, you know, to be able to see next week. I think obviously we all kind of wanted to get going very quickly with this in the context of wanting to try and make as much progress as possible. I think the announcement from SEBC of extending by 6 months the length of the medical supplement plan, you know, and I'm not sure at all what SEBC, you know, plans to do with regard to whether or not July 1, 2024 would be the date in which a blended plan would go live, or if there'll be another extension, or however that would all work out. And there have been people who have asked me about whether or not a 6-month extension means, and ultimately another 6-month extension on top of that to get to end of calendar year. I don't know, but I think it's a great point that as we're trying to work through a whole lot quickly, you know, there's only so much utility to those efforts if data goes out to the committee, you know, very last minute. That has nothing to do with the tremendously hard work of Faith and her team. I think it's just sort of an inevitable development in the process of trying to move quickly with a whole lot of information, and perhaps now with this 6-month extension, we can actually modify the timetable a little bit with regard to still being very productive, but not like at such a frantic pace that we don't strike the right balance, particularly with regard to access of information to committee members. So I think ultimately Representative Blomberg, myself, Senator Governor Hall Long need to huddle up and figure out kind of how to balance all of that in the appropriate way. It's a great comment, and it's not on committee members, it's not on Faith and her team. I think it's on the chairs and co-chairs to figure that out.
Thank you, Senator Townsend. With that, may we go to public comment? If you wish, if you haven't already signed in, please do so. If you wish to make public comment, you haven't already, please do so. We have people who've already pre-registered to speak, correct?
First up is Diana Noonan.
Hi, my name is Diana Noonan, and I'm here representing just my husband and myself. I've looked at the medical benefit chart that has been dispersed to us back in January, and I have a couple quotes. Page 20 of the comparison of plan designs that we just witnessed says there's no co-insurance, no copay. That's just not the case. So let me prove it to you. Your Medicare, first of all, I did this starting out wanting to prove that there were things that are not covered fully under this contract that are covered fully under Medicare. And there's a comment immediately in the chart that says your Medicare covered services must be provided according to the coverage guidelines established for Medicare. While there is nothing really termed co-insurance in this booklet, there is a lot of cost sharing. Here is a quote. For benefits where your cost sharing is a co-insurance percentage, the amount you pay depends on the type of provider you receive the services from. If you receive the covered services from a network provider, you pay the co-insurance percentage multiplied by the plans reimbursed. I'm trying to do it fast so I can get all this in. Reimbursement rate as determined in the contract between the provider and the plan. There's definitely co-insurance, and in that booklet, there are 29 cases of co-insurance. I'm not going to be able to have time to get through all of them, but all of these things are fully covered under Medicare and not fully covered under Medicare Advantage. Ambulance services require prior authorization. Traditional Medicare and Medicare cover all ambulance service costs. Medicare Advantage only covers emergency services if it's pre-approved and if there is no other form of transportation available and if it would endanger the retiree's life. Medicare Advantage does not cover paramedics that provide the care in the ambulance, Medicare paramedics would be an out-of-pocket charge for the retiree. That has something to do with Delaware and Delaware not employing the paramedics through the firehouse. Traditional Medicare also could decide that the transport was not medically necessary and decline the coverage. Inpatient hospital care. Payment for inpatient hospital care starts the day after a retiree is admitted and ends the day before they are discharged. This leaves the retiree liable for full payment of these 2 days. Traditional Medicare and Medifil would cover all the costs for those days. This statement is a little contradictory throughout this booklet, but I'm going page by page in the booklet. Private duty nursing is this is a direct quote from the booklet. Private duty nursing is an acute hospital setting is covered, but you pay 20% co-insurance up to a 240-hour maximum within a 12-month period. Medicare Advantage will pay 100% after the maximum hours are met. The cost sharing for private duty nursing is not applied to your out-of-pocket maximum. There's a list of covered transplants.
Ms. Noonan, you've hit your 3 minutes. Thank you very much. You may also submit your full comments to SCBC@delaware.gov. And we put that in, and that's available to all subcommittee members and the public to read through. Thank you.
Well, can I just say something, Brian? 3 minutes isn't enough to counteract what you guys just put forward, or to give a retiree the opportunity to give input. And I you know who I am. I've read the contract. I've read all the booklets, and what's being presented looks great. It looks like we're going to have 100% coverage, but that is not the case. And there are loopholes and vague literature.
Thank you, Ms. Noonan. Please submit everything in writing beyond the 3 minutes we have each.
Can you give me that website again, please?
I'm sorry, what?
Can you tell me?
It's SEBC, maybe it can be put in the chat, SEBC@delaware.gov.
All right.
Next.
Okay, next up is Mr. Thomas Pledgy.
Okay, can you hear me in there? Okay.
Yes, we can.
Okay. Hi, Paul. Nice to talk to you this afternoon. Couple of quick comments. One is when Faith made her presentation to, I believe it was the Senate on S Bill 29, she asked for 2 senior staff members to add to her staff and $200,000 for WTW consulting services. I assume those jobs are posted and those people are working. Why can't they work over the weekend to get this information out? Wayne has an excellent point. You're burying people, and this is what they do all the time from her office. They bury you in details and minutia. Okay, that's my time, Faith. Second point is I want to make sure that through the lens, which Jacqueline was talking about, that her vision is clear. Based on the data, MA only is only found in 22% of the states. 76% of the states offer choices and supplements. So let's not get misdirected on this. The last point is, and Carol, can you bring up that piece from the contract? Let's do page 10 first, though, of the slides for today, if you could. I know I'm jumping here. But on page 10, it states that under pre-approvals, you're only talking about a small group of pre-approvals. But Carol, if you go to the contract, and I'll yield the rest of my time for you to flip through the pages, look at the list of prior approvals in the contract, please. Paul, take a look at this list and tell me, is this a small list of prior approvals? 41 pages of prior approvals are required. And if these are necessary for Humana, then why does Highmark have different ones? And in the contract, there is a stipulation in there, and Carol can show it to you later, that allows Highmark to change this list at any time without Rents's approval or oversight. So this list of 2023 prior approvals is the beginning list. This list could be 4,000, 5,000. It's just a guesstimate on their part, but look at each one of these items. Again, I think if we're going to hire $100,000 a year employees for rents. They should be working on this stuff. They should be available to you. If we're paying WTW $934,000 a year, they should be doing something for that money. And now they get an extra 200,000 on top of that. Thank you. Have a good day. I'll look forward to the next meeting.
Thank you, Mr. Pledge.
Next up is former Senator Karen Peterson.
I think I hit him enough.
Yeah, they don't want to respond to you.
Senator Peterson, you're up.
See, this is what happens when you lose your connections.
Senator Peterson?
Yes, can you hear me?
Yes, we can.
Okay, thank you. I want to talk briefly about slides 10 and 20. They both show zero costs to members for Medicare Advantage. And I can't believe that anybody is still peddling these claims. It's either willful ignorance or intentional deception. I don't know which. Apparently, WTW has not read Highmark's medical benefits chart because it is full of costs that members would have to pay, including copays, coinsurance, deductibles, and cost-sharing fees. If in fact there were no costs to members, why does page 3 of the chart state that members' maximum out-of-pocket costs are $1,000? How do you explain that? Another comment about page 19. Medicare Part F, and Mr. Tashner mentioned this earlier, Medicare Part F, by the way, it's Part F, not Plan F, is closed only to people now becoming eligible for Medicare. It is still open to those of us who turned 65 prior to 2020. I was able to find a Part F policy last year when I was shopping, when I thought we were going to lose our Medicaid. I found a Part F policy that would have cost me $152 a month, plus $10 to $15 a month for prescription drugs. This should be considered as an option for those of us who qualify for it, and you give us a choice. I thank you for your time.
Thank you, Senator Peterson. Next.
Next up is Donna Dossett.
Okay. All right. Well, I need some clarification on something. What I think I heard was that if I am receiving treatment from a provider that becomes an out of network provider if we switch over to Medicare Advantage, that Highmark will try to get my provider to still accept my insurance and continue my treatment. What happens if I'm not currently receiving services from an out-of-service provider, but a year from now, after we've got Advantage Plan, I do get, say, diagnosed with cancer, and the best treatment for my cancer is at Sloan Kettering, which is not a provider for this plan. What happens then? Do they try to do this, or is that only for people who are currently receiving treatments? I'm not sure I understood correctly, so.
You know about after the meeting.
Okay, right.
Anything else?
No.
Thank you, Ms. Dossett.
Okay.
Next.
Okay, next up is Jeff Altevi.
Close enough. I'm very impressed with all the data. Okay, going through it drives me crazy. I'm sure you're much worse. But anyway, I have two practical questions. I tried to find the Blue Cross network that you keep talking about with the Medicare Advantage. Could somebody give me the website that provides that network? Who's in it? Every time I try to do it, it sends me to a specific state. I then have to enter all sorts of information to get into that state in order to find out if there's or who is a Blue Cross provider. Seems to me in this day and age, if there is a network which is nationwide, somewhere there must be that information. And I can't understand why it's not out there unless there really isn't a network. The second question I have, got time, is facilities and providers of services today in network. Do they sign a contract or can they say tomorrow, we're out of it? How does that work? So just because you may be in network today, how do you know who is there? And I don't know that I have an answer. There must be something. And can people who are in network today get out? Those are my two questions. The data I'll have to look through later. Okay, thank you.
Thank you very much.
Okay, next up is Ted Finley.
Yes, my name is Ted Finley, representative, and I have a couple comments on the presentation. The presenter compared everything to other states, and the state of Delaware compared to all these other states. That's like apples and oranges. Not every state is like Delaware. We certainly don't compare to New Jersey, New York, Chicago, Los Angeles, but all the data seem to be compared to what happens in other states. Why is that? And secondly, the state of Delaware seems to have a lot of money, which seems to be the root of this problem. Last year, they had millions and millions left over of surplus. What happened to that money? Governor Carney is pushing a bill that will reduce taxes and pay earned income more money. And in the future, the marijuana legislation, the recreational marijuana is gonna go once he's gone. And that's gonna supposedly produce a lot of revenue. Where is that money going? Can some of all that funds that I just mentioned be put to causes necessary for the retirees of the Delaware, state of Delaware? That's my question.
Thank you very much. Okay. So if we plan to, I would like to have us go another 5 or so, maybe up to 10 minutes. Hard stop at 10 after if we can. We have 2 online with hands up.
Okay, next up is Mary Graham.
Hi, this is Mary Graham. Can you hear me?
Yes.
Great. Could you please put up slide 11, Ms. Mick? So Senator Peterson talked about she couldn't believe that anybody was still peddling that old information about cost. Well, I can't believe this is still being peddled. This is nothing but an industry mantra talking about the reasons for Medicare Advantage as though they have something to do to help us, to help the participants, and they don't. This is all from the perspective of the insurance industry, a for-profit industry who has a duty to their shareholders to make profits. And we know Delaware is very mindful of that. And they have no duty to you as a patient. So when they talk about, for example, the prior authorization ensures that services provided are reasonable relative to medically necessary standards, they're not doing that. They have computers and they have nurses and non-specialists who look at and make decisions about medical care. And if they make them wrong, guess what? There is nothing any one of us can do about it from a legal perspective. You can go through their appeals process, might or might not work, who knows? But that, of course, also takes time. And so, I mean, a lot of this obviously is the profit incentive that goes on. And one concern I have is that the Medicare contract, the Highmark Medicare contract, has a gain share provision, which could also be called a kickback provision, whereby the state gets certain monies. And this from the profits of Highmark. So it seems to me that the state itself has an incentive for Highmark to profit off of us. And I would be interested to know if anybody has made any projections as to how much money the state will get out of this this incentive provision, this gain share, because it is based on the medical loss ratio, and that has information in it that we can't calculate as ordinary people. So thank you.
Thank you, Ms. Graham.
And next up is former Representative Ray Siegfried.
Former Representative Siegfried, you're up next. Do we need to unmute?
Can you unmute?
I'm sorry. Can you
We're
hear
good.
me?
We can hear you.
Okay, it has been said that Medicare Advantage is a great healthcare insurance until you get sick. And I think that other people have just spoken, point that out. I also want to recommend Representative Bombach. I think he was referring to slide 23, that we obtain the cost per group. I think that that's a great recommendation, and I hope the committee follows suit on that. I would also recommend that the recommendation that Senator Townsend made about really, let's not rush through this. Let's take some time. Highly recommend that. This is far too important to rush through. So I greatly commend both and hope that you go with that. My statement in terms of any kind of pre-authorization, I have to concur with Senator Peterson, as well as what Mary Graham has said. In my mind, there's no reason for pre-authorization other than profit. And to just back that up, let me just explain to you that over 70 congressmen have sent a letter to Secretary of Health and Human Services opening that Medicare Advantage reforms from CMS get implemented sooner than later. Addition, 118 medical societies throughout this country, led by the American Medical Society, also voice support for the CMS proposed rule overhauling the major authorization in Medicare Advantage. Personally, I kind of think the reason why Plan F is no longer provided partially is because Medicare Advantage, as we know, has charged billions of dollars more than regular Medicare for the same procedures. So I think you have heard today, many of us talk against Medicare Advantage for various different reasons. And I hope you consider this. Thank you very much.
Thank you, Representative Siegfried. Mr. Clark. You can unmute yourself. There we go.
Hi.
Yes, you can.
Hi, my name's Bob Clarkin. I've spent hundreds and hundreds of hours, believe it or not, researching this and working with various individuals that have been trying to figure out a path forward. I worked for the Department of Labor for 36 years. I always considered myself a public servant. I wrote hundreds of federal grants, grant applications, plans, budgets. I did the annual state plan for my division. I testified in front of the clearinghouse. I testified in front of the Joint Finance Committee. But always, all of those plans considered the public good. I knew how much money we had from the feds, but I tried to work for the public good and make that money fit the public good. What really concerns me, under MedicFill, I have no barriers to seeking treatment. Under Medicare Advantage, with pre-authorizations and other barriers, I have huge barriers seeking treatment. So one thing I'd like to see, and Secretary Geisenberger has a three-legged stool. I would never sit or stand on a three-legged stool because there's no foundation there. We need to have a fourth leg of the stool. And that fourth leg needs to look at the quality of care and the successful treatment outcomes under MedicFill with no barriers to treatment, no barriers to doctors, no networks, no barriers. Under Medicare Advantage, we've got prior authorizations that nobody really wants to talk about. They get buried in a contract. There are networks. Otherwise, why would the word, I don't see the word network in MedicFill, but I see the word network all over the place in that contract. We have provider hesitancy to participate. We have some providers that won't participate. We have elderly folks in nursing homes who are going to lose their Medicare coverage under Medicare Advantage, or the nursing home does not accept Medicare Advantage. Therefore, I would not do that as a public servant. I'm proud of what I did at the Department of Labor, and I always looked at quality of our services. I wish we would have a fourth leg in the stool and somebody would do a report, maybe WTW would, the quality of service, the successful treatment outcomes under MedicFill, as opposed to the services and outcomes with all of the barriers and all of the problems of Medicare Advantage. And there are a plethora. If you just Google Medicare Advantage, articles that you can
Mr.
read.
Clarkin, you did hit time.
Thank you.
Thank you very much, Mr. Clarkin. Co-chair, co-vice chair, Senator Townsend, any final comments before we adjourn today?
I have no final comments other than I appreciate everyone's input, the public's input, and obviously need to continue to hone in on answers to the questions and more clarity on some of the items, and we're all committed to continuing to do that. And so I think everyone's, continued participation in this exceptionally critical process.
Thank you, Senator. So next Monday, 12 to 2. Also, if you have comments you'd like to submit and have the subcommittee see in advance, SEBC@delaware.gov. Take any final comment. We have a motion to adjourn.
Representative Bomback?
Yes, Representative Ramon.
Michael, I'm only asking because I can't tell virtually. Did we get to address all of the public comment? Everyone got to talk, or did we have to stop it?
We got them all.
Thank you, sir. That's great. I really appreciate it. Yeah, motion to adjourn.
Is there a second? We have a second. We are adjourned. So, there is